Welcome, everyone, to our monthly seminar on research related to spirituality and health. Today, we have George Fichette. Many of you will know George, I'm sure, and know of his work. He is quite an amazing fellow. He is a professor in the Department of Religion, Health, and Human Values at Rush University Medical Center in Chicago, Illinois. He holds a conjoint appointment in Rush's Department of Family and Preventive Medicine with training in both healthcare chaplaincy and epidemiology, and he is one of the country's leading chaplain researchers. I would probably say he is the leading chaplain researcher. 1990, he developed the research program in Russia's Department of Religion, Health, and Human Values, one of first such programs in any chaplaincy department in the country. His research has examined the relationship between religion and health in a variety of community and clinical populations. His NIH funding includes a K Award and an R01, which supported an RCT of chaplain and nurse-led dignity therapy for cancer patients receiving palliative care. He's a co-founder and now senior advisor for Transforming Chaplaincy, whose mission is to advance spiritual care through research. He is recipient of an honorary doctorate from the University of Humanistic Studies in Utrecht, the Netherlands, and a collection of his research, Transforming Chaplaincy, George Fichette Reader, was published in 2021. So we have quite an amazing fellow here to present today on new approaches to spiritual assessment. So George, why don't you take it over?
Harold, thanks so much for the invitation and for the opportunity to be here with you and our colleagues. Really a pleasure. Always enjoy your monthly seminars and your work, and glad to share this work today. So friends, Harold, I hope everyone can see this. It's clear. If there are any problems, give me a shout. But I want to talk to you today about new approaches to spiritual assessment, as Harold said. And let's see if I can get this to unfreeze and advance. It did work before, didn't it?
It did.
Oh dear. Why is that not working?
That's working.
Has it advanced? It hasn't advanced for me.
Yeah, I don't see it advancing.
Yeah, that's not good, is it? Let's. Wow, this is very frustrating. There we go.
All right.
How about that? Did that work?
Share it now.
Share it. There we go. Yeah, let me get back in here.
Yep, that went forward.
Yeah. There's a button down here that I'm not getting to work for me.
Well, take your time, George. We're early on here. Do what you have to. You can even switch computers if you need to.
How about that?
Hey, looks like it's working.
There we go. Good. All right. Thanks, Harold. Appreciate that. Friends, the background, here's the outline for today. I want to share a little bit of background about spiritual assessment. then want to dive into these quantified approaches to spiritual assessment. Some of you will know the SDAT model that was developed 15 years ago by colleagues in Switzerland. And then we have built on that with 3 additional models. So I'll tell you a little bit about that. And then we'll just have a little bit of conversation about next steps in the research, and happy to kind of have time. I think we'll have time for questions and conversation. So, by way of background, it's often important to remember that when we are thinking about clinical inquiry about religion and spirituality in various clinical settings, that there are 3 different levels in which we might make that inquiry, and people sometimes confuse the levels, and so making distinctions about them can be helpful. Spiritual screening is a very brief kind of inquiry about religious and spiritual concerns. Can be 1, 2, or 3 questions done in other kinds of screening contexts. Can be conducted by a variety of different healthcare colleagues. It can be done on a kind of paper pencil survey or a kind of MyChart questionnaire. And you'll see here 3 different examples of some spiritual screening questions. And they're designed to kind of help clinicians identify patients who may potentially be experiencing religious or spiritual concerns, unmet concerns, who should be referred to a chaplain for further assessment. A bit more intensive inquiry about religious and spiritual concerns would be the history-taking models. Very often they're used by primary care providers who are getting to know patients in a broader context of history-taking. And the most widely used model is Christina Polsky's model, the FICA, but you'll see there's some others that have been published as well. And then the most intense kind of inquiry about religious and spiritual concerns for patients is spiritual assessment, generally done by professional chaplains who are trained in spiritual care and spiritual assessment. It is more extensive, often happens in an initial contact with a client or patient, but is also important for it to be an ongoing process. And you'll see there the names of some important models for spiritual assessment that have been published over the last 50 years, if we count Paul Preuser's important minister's diagnostician going back to 1976. So today we're going to focus on the 3rd level, right? The most intense, the kind of inquiries about spiritual assessment. And just a reminder, why is spiritual assessment important? It's the foundation for caring. A number of years ago, pastoral counselor named Don Denton wrote a book called Naming the Pain and Guiding the Care, which was about spiritual assessment. And it's a great summary of the role of spiritual assessment in helping clinicians, chaplains, understand the religious and spiritual concerns of patients and to shape their spiritual care in light of that. But spiritual assessment has an important role in communicating to other members of the healthcare team what is the nature of religious and spiritual concerns of patients or families, what's the intensity of those concerns. And spiritual assessment is really important in terms of evaluating care. If we don't have a good baseline assessment of the needs and resources, it's very hard for us to evaluate whether or not care is being helpful, providing benefits for patients, or whether or not situations are deteriorating. Spiritual concerns are becoming more intense. So just a kind of brief review. But here's where we really begin today's conversation, and that is we've had models for spiritual assessment, published models, for the last 50 years. But I would argue that there are really some substantial limitations for the current practice of spiritual assessment in professional chaplaincy. One of those limitations is that the models that exist are mostly models that I call one size fits all. They were developed for use in every clinical area, same model used in pediatrics, behavioral health, medical rehab, palliative care, ICU, trauma care. And at the time those models were developed, a kind of one-size-fits-all model may have made sense. But over the last 20, 30 years, there's been really important research about religious and spiritual needs of patients with specific clinical conditions. And I think that research can inform what we call condition-specific models for assessment. So I think that's the direction we need to move in. Most of the models for spiritual assessment, with the exception of the Swiss model, the SDAT, have been narrative models, where chaplains summarize the spiritual concerns with narrative statements. And that's, I think, important and helpful, but also limited. Chaplains often use jargon that makes it hard for our clinical colleagues to understand the kind of spiritual concerns that we've identified and the directions for spiritual care. It doesn't really easily translate into communicating the intensity of spiritual distress. And the narrative models really don't allow for reevaluation to determine whether or not spiritual care is addressing spiritual distress and situations are improving or deteriorating, so that for evaluating spiritual care, the narrative models are really limited. So we argue that directions for new developments in spiritual assessment should have at least a quantifiable component adjacent to the narrative model, if not specifically a quantifiable model. The one-size-fits-all narrative models, I think, have been inefficient. I think that condition-specific models, quantifiable models, can be more focused and efficient, particularly to provide useful information for our clinical colleagues. The narrative models, actually, if everyone was using the spiritual aim model, Alison Kestenbaum and colleagues, or some other published model, it would kind of create a kind of common basis for spiritual assessment that would allow for research and for improved communication with healthcare colleagues. But the reality is that most spiritual care departments and most chaplains are using models for spiritual assessment that they developed locally, which means that every time a clinician moves from one clinical context to another, they have to learn the model that the chaplains are using in that center. And it contributes to the struggles that our clinical colleagues have with kind of understanding who we are and what we're doing when we're not using similar models for spiritual assessment. So I'd like to argue for well-established evidence-based models for spiritual assessment that are condition-specific, that are quantifiable, and that have strong enough research that they become commonly used across multiple clinical contexts. So that analysis of where we are with spiritual assessment actually has led to the work that I'll be telling you about. The quantifiable models for spiritual assessment really begin with our colleagues in Switzerland. The team leader was Stephanie Monon at the University Hospital in Lucerne in Switzerland. And they developed a model for spiritual assessment for the geriatric medical rehab unit. And they began by identifying a kind of theory of the spiritual concerns and needs of older adults in medical rehab. And you'll see the dimensions of spirituality that they focused on. And those dimensions led them to a model with 5 spiritual needs. Their work is published in 3 papers. And so those of you who are interested in the details can look up their work. The 5 spiritual needs are in the left-hand column here. And they're designed then to inform a chaplain conversation with a patient. It can be an open-ended conversation. If certain concerns don't come up spontaneously, the chaplains might have these questions that can guide them to ask more about that. Part of what was unique about this model is that after the conversation with the patient, the chaplain would actually provide a score from 0 to 3 that would represent the intensity of unmet spiritual concern for each of the 5 spiritual needs. So patients' scores, total scores, potentially 5 needs, score from 0 to 3. The scores potentially could be from 0 to 15. Um, Part of what caught my attention was not only did they develop what I thought was a very thoughtful model for spiritual assessment, they actually tested the validity and reliability of the model. They came up with reasonable evidence that two different chaplains listening to the same interview with a patient would come up with relatively similar scores on the assessment. So that's the reliability issue. And then they also tested whether or not scores on the spiritual needs, total scores, were related to other measures in ways that you would predict. And they came up with reasonably good evidence for the validity and reliability. I was a little skeptical that they would have that evidence, that chaplains would have enough consistency in their scoring to come up with reasonably good validity and reliability. But in fact, they showed that chaplains could be quite consistent. And so that caught my attention and led me to think we should build on their work. Let me just say that in addition to kind of guiding the care for individual patients, when you have quantifiable models for spiritual assessment, you can summarize the acuity of spiritual distress in a population. And so one of the things that the team did was to aggregate their chaplaincy scores about spiritual distress, in this case for 203 of their patients, and you'll see the distribution in the graph, but more importantly, the notes on the right-hand side, they found that 2/3 of these patients had some distress. 1 out of 4 had some distress in all 5 of the dimensions. And for 1 out of 5 of the patients, there was actually severe distress in at least one of the dimensions. And that was most likely the search for meaning, or what they called life balance. And so when you have this kind of information, you actually have the basis for, you have a kind of empirical basis for summarizing the acuity of spiritual need in a population, and for planning for the kind of spiritual care services that would be necessary for both assessment and spiritual care for that population. It's a very powerful resource for particularly chaplaincy managers who are talking with healthcare managers and healthcare colleagues about providing spiritual care, adequate spiritual care services to address the spiritual needs of a given clinical population. As I said, we were very impressed with the work that our Swiss colleagues did, particularly around the quantification and the validity and reliability. So this team went to work building a model for a quantifiable approach to spiritual assessment for patients receiving palliative care. And the model has been called PC7. We built our model of spiritual concerns for these patients not on the spiritual concerns of the Swiss geriatric medical rehab patients, but on what we thought were kind of common spiritual concerns for palliative care patients. And so we made use of Karen Steinhauser's measure of quality of life at the end of life, called the QALY, and particularly her conceptualization about preparation for the end of life and a sense of life completion. And then we also made very strong use of Ken Pargament and colleagues' models for religious and spiritual struggles. And so that helped build our themes, the rows in the model, if you'd like. We used the scoring from the SDAT team, and we revised our model over 2 years, actually, based on monthly case discussions in which one of the chaplains on the team would distribute a case. We would all use the latest model of the PC7, latest version of what became the PC7 to score that. We would then have a discussion about why our scores were similar and different. And gradually we kind of elaborated the themes in the PC7 and also improved the consistency of our scoring. The PC7 wound up with these 7 themes: need for meaning in the face of suffering, need for legacy, kind of a generativity theme, concerns about relationships with family and significant others, concerns about or fears about dying, concerns about decision making, about treatment, straight up religious and spiritual struggles, and then we left a space for other. And so similar to the Swiss colleagues who kind of developed questions that could be used in the conversation with a patient, we kind of identified our themes, and then we created descriptors or indicators that help the chaplain identify whether or not the distress fit in the one particular theme or another. The bottom row here, concerns about relationships, families, significant others. You'll see actually it turns out to be one of the most prevalent concerns. And so some of the details here are that cases where patient has unfinished business with significant others, they have concerns about family's ability to cope without them, concerns that they're a burden to their family or they're experiencing loneliness or isolation. I'm not going to go into all the details about all 7 themes. You can look them up in the article and read more about them there. As we worked on the model, we realized we needed to identify some factors that would help focus the work. So while we call the model PC7 and it focuses on palliative care, it's not meant for all palliative care patients, but it's actually meant for patients with life-limiting illness who are receiving palliative care. We recognize that's not who all the palliative care patients are. The model focuses on assessment of the patient as an individual and is not a model that focuses on assessment of issues for the family. And so it does have that limitation. We make our scores based on explicit spiritual concerns and not chaplain's hunches that there may be something else going on. People have said, well, what about the resources? You're only focusing on the needs, not the resources. And that's actually not quite true. The score for spiritual need that the chaplain gives for a theme should be taking into account the resources the patient is bringing, individual, personal, spiritual resources, interpersonal, communal kind of support from religious and spiritual communities. And once you've taken into account those resources, are there unmet spiritual concerns that are still there that need chaplain's attention? So that's an important factor to remember as you think about the scoring. This is the same scoring as the Swiss team, except that we added 0 asterisk. Our chaplains, as we were developing the model, said, I think something else is going on with this patient. And I would push back and say, well, where in the verbatim, where in the conversation was that concern expressed? And so that's where we kind of said, if the concern is not explicitly stated, then it's the score doesn't take into account the chaplain's hunch. But the chaplain's hunches can be indicated by a 0 asterisk. And for purposes of summary, totaling the scores, the 0 asterisk is treated as a 0. The yellow highlighted data here is important, and that is a score of 2 or 3 for any theme implies a level of unmet spiritual concern that should be addressed in a chaplain care plan and follow-up. And for our analysis, what we are using is the number of the 7 themes. How many of those 7 themes had a chaplain score of 2 or 3? So potentially the score can be 0. There were none of the concerns had a chaplain score of 2 or 3, or the score can be 1, 2, 3, 4, 5, 6, 7. So it's important to remember that on one hand, themes get scored from 0 to 3, but for the purposes of analysis and reporting and describing spiritual need, we focus on that 0 to 7, the number of themes for which the chaplain identified moderate or severe unmet spiritual concerns. So I just want to quickly take you through some research we've done about the validity and reliability and clinical usefulness of the PC7. For validity, we asked the patients to complete the spiritual struggle scale from Julie Exline and Ken and colleagues. The spiritual pain item, are you experiencing spiritual pain, is 0 to 10. Spiritual pain is pain deep inside that's not physical. And then we also used Karen Steinhauser's quality, and then we did reliability as well. So the data I'm sharing with you come from 110 palliative care patients. 2/3 of them were inpatients, a third of them were outpatients, a couple of them were home palliative care patients. They basically came from 3 medical centers here in the Midwest, in Peoria at OSF, at Northwestern here in Chicago, and Essentia Health up in Duluth. I'm not going to dwell on the details of the patients. 60% were female, 80% were white. A little over half had a cancer diagnosis. Palliative performance scale kind of tells you how much functional disability is associated with the patient's illness. About a third of the patients were really pretty ambulatory and pretty functional, but 2/3 had different levels of functional impairment associated with their illness. And patients' time since diagnosis, on average, was about a year. The patients were a pretty religious group, and 17 chaplains provided the spiritual assessments. 4 of those chaplains provided the vast majority of the assessments. You'll see in the little table off to the side here that 4 chaplains did between 18 and 24 assessments. Some chaplains only did the inter-rater reliability assessments. Of the 17, 10 were board certified, and they had between 3 and 30 years of experience in chaplaincy. The median was 9 years of experience in chaplaincy. So this is a pretty experienced group of chaplains, and we trained them in the model. They did some scoring, compared scores on a couple of cases, and we found pretty good consistency. And so among the 110 patients, 57% had no moderate or high concerns on any of the 7 themes. 28% had moderate or high concerns on at least one theme, and 15% had moderate or high concerns on 2, 3, or 4 concerns. So, 43% would have clinically significant spiritual concerns, is our way of interpreting this. You'll see here the most common spiritual concerns were around relationships and meaning and legacy, a little less for dying, a little less for religious struggle, a little less for treatment decisions. The PC7 total was significantly correlated in expected directions with the other measures we use: spiritual pain, total religious struggle, quality, preparation, and completion. I'm not going to get into these weeds. It's just designed to kind of show you that we then actually looked at the 7 themes in the PC7 and their associations with our validity measures, and there were associations in expected directions for the specific themes as well. And this is the reliability. We had 57 cases where we had 2 chaplains independently assessing, and the correlation coefficient for the 2 chaplains was 0.402. And then we had 54 cases where the chaplain did the assessment. We locked it up in a drawer. 3 months later, they listened to the tape again and reassessed, and the intra-rater reliability was 0.593. So reasonably good, could be better, but not bad. We asked the patients after the chaplain interview, the research assistant asked them about their experiences with the PC7, and 90% reported something that was helpful, that they liked it. 90% reported the time that it took to do the assessment was just about right. And you see some of the comments. The patients felt they were heard and understood and had an opportunity to think through things that they hadn't thought through before, and generally were appreciative. So by way of summary, the PC7 we think is a strong and useful tool for spiritual assessment. It yields a quantified description of the patient's unmet spiritual concerns. We think it has reasonable evidence for validity and reliability. and patients seem to appreciate the interviews. So we've gone on and developed one other model, which we call the ONC5, and there's a third model in development called the GERO, and I'll tell you about both of them. This is the ONC5. It has the first four themes are similar to the PC7, and the fifth theme focuses on values or duties and obligations and is designed to kind of assess patient struggles with alignment between beliefs and values and medical decisions and or feelings of guilt or responsibility around things they might have done that contributed to their illness. Three colleagues of three different, in addition to Rush, colleagues at two different medical centers have used the ONC5 in different clinical research projects. At Rush, we used the ONC5 in a study of 71 cancer patients in our outpatient infusion center. Our colleagues at Ascension developed an outpatient, tested a model of spiritual care for cancer outpatients, and there were 27 patients in that pilot project at baseline, and the chaplains used the ONC. It was actually ONC6 because there was an other at the time in their spiritual assessments of those patients. And colleagues at Mayo, Florida, have used the ONC5 in a study of spiritual screening and spiritual assessment in patients in their palliative, the neuro-oncology clinic. And it's important to note that the Mayo patients, there were 40 Mayo patients, they had been screened by a social worker using spiritual distress questions, and based on positive screen with the spiritual distress questions, they were then referred to the chaplain for additional, more intensive spiritual assessments. So you'll see there's a higher level of distress in those patients, in part because of the prior screening that had happened. You'll see here across the top, in our 71 patients at Rush, we found 1 in 5 had at least one moderate or severe spiritual concern on the ONC5. In the Ascension sample, it was about half, and in the Mayo sample, it's about 2/3. And you'll see here the pattern of where the most intense spiritual concerns are. Meaning and relationships continue to be two of the areas of most intense concern for these patients. We did a little bit of work about validity for the Rush outpatients. You'll see we had a version of religious and spiritual struggle scale, and there was a reasonable correlation there. And we used some other measures of testing validity, and for a variety of reasons, the summary of the ONC5 scores were not really strongly associated with those. In the Ascension sample, there's actually 4 different tests of validity and really quite strong correlations between the ONC5 score and those others. And then among the 71 Rush patients, we actually recorded the interviews. We had for 30 of the patients, we had a second chaplain listen to the recordings and do the assessments, and the correlation coefficient was 0.44. So a reasonable level of reliability. And our final model is the GERO, and we don't have a number yet, but the team working on the GERO has identified 4 themes: meaning, identity, relationships, so it's called connection here, religious, spiritual needs. And this is a team that's focusing on developing a model for spiritual assessment for use in older adults who are primarily in residential care, of some kind of long-term residential care for older adults, nursing homes, continuing care, retirement communities, assisted living. And so we've been working on the model for about a year. We developed our themes based on the literature and other models, and we've discussed 5 cases now, and we're going to discuss another 3 cases or so and fine tune the model, and then hopefully we'll publish it and present it so that colleagues can begin using it in other settings. So Harold, I'm coming down the home stretch here. I think we're going to have time for conversation and questions. I just want to kind of say, here's the big picture. I think we've developed a suite of quantifiable models for spiritual assessment for use in specific clinical contexts, and that our work is providing growing evidence for the validity and reliability and clinical usefulness for these models. Our work obviously has lots of limitations, and among them are the fact that the current evidence about our models comes from small samples, and in many cases, the samples have limited religious and racial ethnic diversity. So there's a lot of research that we'd like to do about this work to continue to examine the validity and reliability, continue to examine the prevalence of spiritual distress in different populations. We'd like to get more information from the chaplains about their experiences with the model. We did ask the chaplains using the PC7. We had some focus groups with them and asked them about it. And we asked the chaplains with the ONC5. We had a focus group with them and asked them. And chaplains are generally appreciative of the models. They've made some suggestions about how to work with them. They've also indicated that learning to use the models does take a while and needs some practice. We don't have good data yet about the usefulness of the models for communicating with interdisciplinary colleagues, and so we need to get some data about whether or not the models are as effective in that communication as we'd like them to be. And then, in addition to kind of identifying, describing the prevalence of spiritual concerns in general, we need to also examine whether or not the models are kind of performing in a consistent and effective way across religious and spiritual and racial ethnic subgroups. So there's a lot of additional work. I just want to let people who are on the webinar today, those who might listen to the recording, know that use of the models doesn't require permission. The PC7 model is published. I'll show you the citation in a minute. The ONC5 model is published, and people are just welcome to kind of pick them up and begin using them. If you would like to communicate with us about your experience with the model, we would love to hear from you about that. We plan to do some training for colleagues who are interested in using the models in the winter. And so if people are interested in our training, they can send me an email and we'll keep you posted about that. And we're very eager to kind of do further research, as I described, about the models. And if people would like to partner with us and help us provide support to do that research, we would love to hear from you. It takes a village, as everyone on this call would know, and so I just want to express a very deep gratitude to the people who have collaborated with us on all of this research. You'll see the colleagues who helped us collect the data for the PC7 model and helped with the analysis. The PC7 research was funded by a grant from Oncology Health Sciences at Rush, for which we're very grateful. The 5 different ONC5 research projects, again, very grateful for the colleagues who collaborated on each of them, who are identified here. Again, the Rush project was funded by a grant from our College of Health Sciences. The Ascension project was funded by Ascension. The Mayo project was funded by a grant to the chaplain manager at Mayo, Bibatata Mbang, and that was a grant from GWISH. So appreciate all that support. And I know some of the Gero team is on the call, and we want to acknowledge them and their enthusiastic kind of collaboration in helping us develop the Gero model. So as I mentioned, first reference is the current reference for the PC7. The last reference is for the ONC5. The Ascension Oncology Outpatient Spiritual Care paper has also been published. The paper about the validity and reliability of the PC7 is written. I need to edit it in the next few weeks and share it with the team. And we hope that that paper will be submitted early in the new year. And we continued research around all of this. So, want to thank you for your attention. Eager to hear your comments and questions. And I want to give a shout out to Transforming Chaplaincy. Some of you were on the call before we got started, where Harold and I were talking. Transforming Chaplaincy is a kind of national, international network of chaplains who are coming together to advance spiritual care through research. Wendy Cadge and I founded it in 2015 with a very large grant from the Templeton Foundation and from our professional chaplaincy organizations. And then in 2019, the Templeton grant finished, and we've moved into another phase with support from healthcare systems. We're very grateful for the support for Providence Health and IU Health in Indianapolis and Cedars-Sinai in Los Angeles, and glad for other partners. But if you're not familiar with Transforming Chaplaincy, do check out the website, www.transformchaplaincy.org. Get on our newsletter. It'll keep you up to date about the kind of spiritual assessment research we're doing. We do a lot of work on mapping spiritual care. What is the nature of spiritual care services being provided in general hospitals and in cancer care and in nursing homes and in pediatrics? So we do a lot of the mapping studies. And we're also involved in research around effectiveness of chaplaincy and research literacy for chaplains as well. So always glad to hear from you and encourage you to sign up for the Transforming Chaplaincy newsletter. And we do a lot of free webinars, and glad to be in conversation. Harold.
George, what a terrific presentation. My gosh. Okay, you all, now it's your turn, members on the call here, to ask George some questions. So unmute yourself and ask a question. And I'll call on you when you unmute yourself. Okay, Jeremy, first person to unmute himself. Go ahead.
Yeah, thank you. So with PC7 being palliative folks and the other one kind of being older folks, do we have parallels or evidence-based assessments for pediatric populations?
Our team hasn't done that. The Transforming Chaplaincy research focus right now is in three specific clinical areas: spiritual care and spiritual needs and palliative care, spiritual care, spiritual needs and oncology. And the third area, actually, Jeremy, is pediatrics. And Kate Desjardins on the Transforming Chaplaincy team leads our pediatrics initiative. And some of Kate's research is around best models of spiritual assessment in pediatric spiritual care. And so she's kind of leading a team that is identifying best models for spiritual assessment. And I think they're currently kind of did some brainstorming and focus groups about that, and they're in the process of writing that up. I don't think Kate's on the call, but Kate, if you are, you should actually correct me here. And we hope to see that paper. And Transforming Chaplaincy, obviously, we'll do a webinar about that, hopefully in the next 6 months or so. So it's an important area. The team is not actually moving in the direction of quantified spiritual assessments, as far as I know, but it's actually Kate's leading that initiative, and you can find her contact information on our website, and I'm sure she'd be glad to stay in touch with you about that. Thanks, Jeremy. I'd see, actually, I've got my screen up here. I see colleagues from a number of different places who I've named as the contributors here, and I just want to give them a shout out. My screen is only showing about 20 people right now, but I see colleagues at Vanderbilt. Our colleagues at Vanderbilt and Mass General also did some work with the PC7 that we'll be reporting on later about the prevalence of that. And so Ian and colleagues at Vanderbilt give you a shout out for that. Kathy Ulrich, I see, is on the call. Kathy was one of the chaplains who helped with the PC7. And so, and I'm not seeing everybody right now, but I do want to kind of give a shout out all of you who were contributors and helped. Harold, back to you.
Okay, Alamitu is the next person up to ask his question. So go ahead and unmute yourself. Go ahead.
Thank you so much. Thank you for the nice presentation. So I am Alamito Bezaple from Computer Science Department, Colorado School of Mines. So we research spiritual care in online spaces. So how technology can actually be used as a mediator for spiritual care. Thank you so much. So I am new to the discipline in that case. So my question is like, how do we have like assessment tools? You said that tools should be condition specific or disease specific. So do we expect like to have assessment tools for every disease, or how do you manage the granularity of like this could be like a very simple question for you, but I'm just curious to know like what will be how do you balance between having one model fits all and then also like disease specific? So how do you balance this granularity of like models? Thanks so much.
Yeah, Alamito, that's a great question. Sorry about that. It seems insane when you think about all the clinical populations to have chaplains have to learn the spiritual assessment model for every different one. That just seems nuts. Why am I heading down this road? And so it may be at some point we're going to decide, oh, that was a mistake. But right now we think it's actually not completely a mistake, that there are distinctive clinical concerns in different clinical populations, older adults, medical rehab, obviously pediatrics, mental health, behavioral health care. And so we think that there's some validity for condition-specific models. But what are the limits to that? We haven't found them yet. It's obviously we're going to bump into them, and we need to give some thought about how realistic it is and what it will mean. I see Maya has a question here. I wonder if eventually there'll be a more generic model. It may be that that will happen. But we're going to kind of work our way through condition specific for a little while and see how that goes. And we're glad for colleagues to share their opinions and experiences about that and their suggestions about how we move forward. Thank you. Yeah.
Great, George. Francis Lou's next up. Francis.
Yes, am I unmuted?
Yes, you're unmuted.
Okay, yeah, George, thank you very, very much for a wonderful presentation. I just had a question concerning the last three scales that you discussed. In the first one, you had religious or spiritual struggle, and then in the second one, it was religious, spiritual, or existential issue, and then in the last one, the ONC5, there was something around religious or spiritual needs. And so I'm just wondering, two questions. One, do you see those three categories as somewhat in the same ballpark, first of all, even though the last one is called needs? And then the second question is, do you see the work of Ken Pargament and Julie Exine on religious and spiritual struggles as fitting in to those categories? Again, ballpark.
Yeah, Francis, great to see you. Thank you for the question and actually kind of sharp observation, right? Is that there's a way in which the three models are beginning to have themes within them that are similar. But we actually have different names for them, and it's going to confuse the hell out of everybody if we don't straighten this out. So up till this point, we've kind of, the team that developed the model came up with its own language for the names, and we put it out there. But at some point soon, we're going to actually have to get consistent so that the same thing is described with the same title. And right now, they're mostly the same thing, but they do have these unfortunate different titles. But you're also quite correct in that is that the work of Ken and Julie on developing spiritual measures of spirit, conceptualizing religious and spiritual struggle and measuring spiritual, religious, spiritual, has been core to our work. We're actually not finding, as you saw when we kind of looked at the prevalence of struggles across the different themes, we're not finding that those are the most dominant themes. The most dominant theme tends to be around relationships or meaning for these different populations. But there may be about 10% of the patients for whom there's a kind of straight up religious or spiritual struggle theme. Thank you, Francis. I appreciate that.
Yes, and one of the six spiritual struggles is ultimate meaning.
Yeah.
So there may be some link there too. Thank you very much, George.
Exactly, Francis. So I think we started the PC7 work maybe before we were aware that ultimate meaning was actually one of the six RS struggles, but it's obviously consistent with that. Harold, I'm seeing some messages in the chat where people want to know about the training and people want to know about how to get the copy of the articles. And the thing to do is actually for people to send me an email because I'm not going to be reading the chat or copying the chat. So my email address is my name. It's George with an underscore and then Fichette at rush.edu. George_Fichette@rush.edu. And I can send you the PC7 paper and we'll put your name on the list to be notified about training.
Great. Sounds good. Chaplain Beth is next.
Yeah, yes. Real quick, so I've been noticing after reading that article, that kind of started me on this road, that faith communities have a contribution in spiritual health. Are you doing any research or considering inviting some faith communities into your project to look at ways that they could be better participants in this work?
Yeah, thanks, Beth. That's a great question. At this point, that hasn't been part of our work. Our work is kind of focused on the patients who are in our clinical environment and trying to assess the religious and spiritual concerns and the best ways to meet them. And as I mentioned when I was kind of talking about the details, our kind of scoring of spiritual concern is a kind of assessment of the intensity of spiritual concern that takes into account whether or not a patient has support from a spiritual community. So I think chaplains have always been very sensitive about support from spiritual communities, whether it's there, whether not there. And so for the individual patient, we are interested in whether or not they're part of a community, a supportive community of faith, how much support they're getting, and to what extent then the chaplain's care needs to complement that. But we also are informed, to kind of go back to the comment from Francis, right, that one of the types of religious and spiritual struggles that Ken Parkman, Julie Exline, and their colleagues have identified is what's called interpersonal religious spiritual struggle. And interpersonal religious and spiritual struggle could be your pious uncle who said if you'd only prayed more, you wouldn't be sick. Or it could be actually a congregation where your experience has been the congregation has been kind of judgmental toward you, or religious leaders who have been outright abusive. So experiences in religious communities we recognize can be both positive and negative. And we do take that into account in the spiritual assessment.
Very good. Okay, Bart, you're next.
A quick question though, George, thank you for reviewing some of the validated assessments and tools. Great presentation. My question to you is related to current charting platforms. So, are they integrated into current charting platforms? Like Epic is one of the largest vendor for charting across the globe. There are many others besides Epic, Meditech, Cerner, Clinical Sorian. So I think there might be a value in, like Epic has Epic User Web, so where the assessments are available for different organizations to pick and choose. There might be value in placing some of these validated instruments into the libraries, whether it's Epic or other platforms. So are these tools available in some of the charting platforms?
Yeah, Bart, great to hear from you, and a wonderful question. Thank you. We haven't been in touch with Epic to try to get these established there. I think in the chat we just saw a note from Bert, right? And maybe Bert can come off mute and actually comment on that. Because some of the people who have worked with us, Burl and Steve Drennan have built the PC7 into their local Epic, and so it has begun to happen. Burl, do you want to comment on that?
Yes. Hello, everyone. I can't take exclusive credit for getting it built into Epic. I think Steve was a part of that process, but I can say that we initially put the PC7 into Epic almost midway through our research project, and our chaplains have developed quite a bit of experience with it. And within the Epic system, also in another system we use in the hospice space, remote client as well. So we've had some really good experience, and our chaplains so far have really appreciated having that assessment tool in there. And I'm sure that Steve is on as well. Perhaps he could speak to the actual build.
Thank you, Burl, and thank you, George. Yes, we had our team locally build into Epic, as Burl mentioned, the PC7 tool itself, and with different adaptations, and it is shareable with the rest of the interdisciplinary teams on floors on any unit. In fact, you can go ahead and email us directly if you like. Maybe someone just suggested putting in the Epic user web. Yeah, so our system definitely open and available to share if anybody would like to see it built in Epic and in Epic Remote Client.
Steve, Burl, thank you for that. Steve and Burl were part of the OSF team. That was such an important contributor to the research about the PC7 that I shared earlier. So, Steve or Burl, if you want to put your email in the chat, and people can reach you directly. If folks don't get that email and they want to email me, I'll pass it on to Steve and Burl so that you have that. But yeah, so people have begun to kind of put the models locally into their Epic systems, and then the ways in which people can share things in Epic, and Epic might as Bart said, there might be ways to download it from the Epic Share. Yeah, good. Great to see you guys in person. Yeah. Harold, I see Angelica Zolfrank has a question.
Okay, sounds good.
Yeah, hi. Thank you so much, George, for your incredible work and your presentation, which was, as always, super informative. I guess I have one main thought before we're building Epic and all that, which is to make sure that these instruments are valid across races and ethnicities and religious diversity. I worry that we're too quickly jumping to conclusions there. It seems like, understandably, that white samples are always easier to get, but just yeah, wondered about that and wanted to share that concern.
Angelica, yeah, thanks. I mean, I think that's spot on. I really would be more comfortable if we had more research before we were building things in Epic as well. But there is also, in some sense, a need. Chaplains want to kind of do the best they can with the spiritual assessment. The tool seems useful, the tool seems helpful, and so people are picking it up. And that's great to see. But if people are interested and want to do research with us, where we can, in fact, be sure that we have the best level of training and the highest level of reliability, and that we then can do some research where we can examine whether or not the tools are valid in important religious and spiritual subgroups, as well as racial, ethnic, minority subgroups, is exactly right. It's kind of key areas for future research. So if anybody has a family foundation or their hospital has a foundation, or you have some other ideas about places where we can get grants to kind of continue this work, we would love to kind of be in touch with you to do that. Harold, we've kept everybody busy for an hour.
We have, George. And of course, you have been spectacular, as I would expect you to be. I just wanted everyone to know also that George's a PDF of his slides will be available on our website, as well as a recording of his talk. So all you have to do is just put in Duke Spirituality and Health in your Google search engine, and it should come up with the Center for Spirituality, Theology, and Health. And on the home page, there will be a link for the seminars. And so in any case, thank you all for all your great questions, and hope to see you next month in our next seminar. Take care. God bless.